Welcome to a new podcast episode of Radiology AI. My name is Dania Daye, and I'm the Associate Editor for Social Media for Radiology AI. And today, my co-host Paul Yee and I are very excited to bring a new episode of the podcast series. Today, we will be interviewing one of the pioneers in our field, Dr. Ronald Summers. We will be hearing from him about his journey in imaging and AI and his vision for the future. Dr. Summers, thank you for joining us today. First, I will start with a brief introduction. Dr. Summers is Senior Investigator in the Imaging Biomarkers and Computer-Aided Diagnosis Laboratory at the NIH Clinical Center. He holds a BA degree in physics and an MD and a PhD in medicine, anatomy, and cell biology from the University of Pennsylvania. He completed a medical internship at Presbyterian University of Pennsylvania Hospital, a radiology residency at the University of Michigan, Ann Arbor, and an MRI fellowship at Duke University. In 1994, he joined the Radiology and Imaging Sciences Department at the NIH Clinical Center in Bethesda, where he is now a tenured senior investigator and staff radiologist. He directs the Imaging Biomarkers and Computer-Aided Diagnosis Laboratory and is former and founding chief of the NIH Clinical Image Processing Service. He has received numerous prestigious awards, including the NIH Directors Award and the NIH Clinical Center Directors Award. Dr. Summers has co-authored over 500 journal review and conference proceedings and is co-inventor on 14 patents. He is a member of the editorial boards of the Journal of Medical Imaging, Radiology AI, and Academic Radiology, and a past member of the editorial board of Radiology. Dr. Summers, thank you for joining us today. I will turn it over to my co-host Paul for the interview.
Dania, thanks so much for the introduction. And thank you, Ron, for joining us today on the Radiology AI podcast. It's a real pleasure to have you here.
My pleasure to be here. Thanks so much for inviting me.
Ron, you've had a really interesting career in radiology AI, having directed the Imaging Biomarkers and Computer-Aided Diagnostic Lab at the NIH and pioneering numerous areas in the field, including one of the first large publicly available chest X-ray data sets. Can you tell us about your background and how you got interested in AI for radiology?
Sure. It's hard to know where to start, but I was always interested in computers. When I was an undergrad at the University of Pennsylvania, I was a physics major, and I briefly considered being a computer science major. But at the time, computer science, which was actually focusing on AI, was really interested in things like understanding language, and they were using a programming language called Lisp that I found quite impenetrable and incomprehensible. I thought they were so, that the field was just so bizarre at the time that I couldn't motivate myself. Computer science. So I did physics, and then I went to medical school, and I've always been interested in things like simulation and image analysis. I did an MD PhD program at Penn, and my PhD was on sodium MRI, and that involved such things as building RF coils, radio frequency coils, and getting pulse sequences to work, like projection reconstruction techniques. So I always had a little bit of coding in my background, and ironically, at the time, the image reconstruction was done using what today we would call a GPU. Back then was called an array processor. And at the time, I thought to myself, well, that array processor is really fast. I wonder what it could be used for to do faster computing. And now here we are today with these GPUs doing computing, orders of magnitude faster than the CPU and being used for deep learning. So, through residency, I was interested in computing, but there weren't many opportunities because residency was so all-encompassing. Took all my time to learn radiology. But then when I started at NIH, at the time, visualization was a big topic, and virtual endoscopy became pretty big. And at that time, there were the precursors to GPUs everywhere was these visualization computers from a company called Silicon Graphics, which still sort of exists, but not anywhere near its former glory. And I started working on virtual bronchoscopy at that time, I was inspired by somebody from Hopkins, actually, who was very big on virtual endoscopy at that time. And then when virtual colonoscopy came along, I realized that I could apply many of the things that I learned from virtual bronchoscopy to the colon. And what was so much more appealing was that whereas airway disease is relatively rare, aside from asthma, which we don't typically image with CT, precancerous polyps are relatively common, and colorectal cancer is the second leading cause of cancer death in Americans, as it still is today. And so it was a natural transition for me to move from the visualization aspects into the computer-aided detection aspects. So I spent quite a bit of time working on virtual colonoscopy and using pre-deep learning techniques to try to figure out how to detect polyps. And towards the end of that phase of my career, we did manage to get sensitivities of around 90%, especially for the bigger polyps. But the false positive rates were, we considered to be relatively high for 1 centimeter and larger polyps, which was the primary goal of the research we had. I think we had about 2 to 4 false positives per scan. And then for the 6 to 9 millimeter polyps, which was the secondary category that was important for colorectal cancer screening, we were still getting high sensitivities, but at the cost of very high false positive rates. We tried everything we could think of to get those false positive rates down, and nothing seemed to work. And it wasn't until about 2012 or 2013 when I heard about deep learning that I realized that the problem wasn't what we were doing. The problem was that the part of the computer-aided diagnosis system that did the classification wasn't good enough. We were using something called support vector machines, which at that time was the state-of-the-art machine learning classifier. Just for those who don't know, a classifier is the software or the algorithm that takes a list of possible detections of pathology and reduces it to a much smaller set, which would then be presented to the radiologist for clinical use. And that step, that classification step, is key, because if you don't have a well-functioning classification step, you get lots and lots of false positives, and it makes the AI system not clinically useful.
Yeah, Ron, that was super interesting. I didn't realize that you had started out in physics and then eventually made your way over to the NIH. I think it's really interesting to see how you've pioneered a lot of these tools over the years, ranging from CT virtual colonoscopy to other bleeding edge technologies. Like even today on a population scale, you're talking about how colon cancer affects so many people around the world. I've really enjoyed your work with Perry Pickhart, looking at population level measures of things like the amount of fat that's in a person's body, both visceral and in subcutaneous, the amount of muscle, things like osteoporosis. It's quite a tremendous amount of material and breadth of things that you've been able to study and become an expert in. So I'm curious, over your career, how have you managed to keep up with all of these developments over time, particularly as things in fields like computer science, like artificial intelligence, move at such a breakneck speed?
Yeah, it's not easy to keep up. And you're right, the field is moving so ridiculously quickly that things are changing all the time. For example, there was a period of time where the deep learning architectures were changing on almost a monthly basis. And these deep learning architectures, which is the means of converting the images into the diagnoses, they started small and they rapidly became bigger and bigger, in large measure because some of the big companies like the Microsofts and the Googles and the Facebooks and other companies were coming up with better and better deep learning architecture. So that was a period of very dynamic change that lasted several years. And that particular phase has settled down a bit, and lots of researchers in radiology using the deep learning architectures that were developed several years ago. Even though new techniques are coming out, they don't seem to provide as much bang for the buck as the techniques that developed a few years ago. So, but then you had things like variational autoencoders and generative adversarial networks. So then there was a whole new group of things to understand and try to figure out what they were good for and why we should think about using them for radiology. Now we're kind of in a phase where the computer science parts have settled down a bit. Of course, they're not stationary, they're still moving at a rapid pace. At least my view from the radiologist perspective is that things are settling down. In my research group, we have regular literature review discussions. So members of the group pick up an impactful paper that they've heard about either through social media or through literature searching. And we try to keep up with that, but we can barely scratch the surface. For example, during the COVID peak last year, the AI papers about COVID were coming out at the rate of tens of papers per day at the beginning. It was just crazy. And there was no way to keep up. But the perspective that I've had is that it isn't necessary to know everything that's going on. You can do a lot with just understanding that high level, just having a high level understanding of what's going on in the field is good enough to do very impactful work. So I try to keep up. My group tries to keep up. We have literature reviews. Each member of the group has a different way of learning about what's hot in the field, be it different blogs and Twitter feeds and other means of keeping up, radiology, AIs, tweet chats. I mean, there's just so many ways to find out what's interesting, but I know I can't keep up on everything. So I just try the best I can.
Yeah, I think that's super interesting that you mentioned that you started thinking about deep learning back in 2012, because to my recollection, at least in the radiology journals, I think the first deep learning paper I came across was in either JDI or in Radiology back in 2017. I think in JDI, I was at Brad Erickson's group looking at glioblastoma mutations on MRI. And in Radiology, one of the first ones was Paras Lakhani's paper from Jefferson on tuberculosis on chest x-rays. But as you noted, in 2012, that's when AlexNet was introduced at the ImageNet Large-Scale Visual Recognition Challenge. And this is something that John Mongan, who had been a guest on one of our prior episodes, noted that deep learning had been around for a little bit. And one of his colleagues told him, hey, listen, I think this is going to make a big splash in radiology. But I think one thing I've observed is, as you mentioned, we're kind of behind the technology quite a bit. But at the same time, I thought also maybe that could be to a benefit, given that there are pitfalls with these techniques and these different types of technologies. For instance, shortly after those papers came out in the ensuing years, we've seen how deep learning models can pick up on confounding factors such as the laterality marker or figuring out what hospital did it come from if the disease distribution differed between them. So I wonder if that might be actually a benefit there. Overall, has the development and course of deep learning radiology been surprising for you?
It's definitely been surprising because it's evolved so quickly. I was used to working in a relatively slower moving field of computer aided detection, or CAD, which was in some ways a backwater, mainly because the false positive rates were so high at the time in order to attain sufficient sensitivity. So while we published in radiology journals prior to the deep learning era, there wasn't as much impact. And then I know for, getting back to the earlier part of your last comment, I was kind of primed for the deep learning era. And that's one of the main reasons why I jumped into it so quickly and so early, because I was just so frustrated with how poor the performance was for the computer-aided detection, which now we're calling AI and machine learning. But it's the same as the computer-aided detection, that field that we had prior to deep learning. There's really no difference. But the renaming seems to have been helpful, as with many things in radiology and other parts of life. So we were publishing in medical imaging conferences for quite a number of years. And I felt, as soon as I saw the first paper on deep learning in radiology by Lakhani, I thought to myself, why is radiology like 3 to 4 years behind everybody in the medical image processing community? I'm not even talking about the computer science community, who were even further ahead, because there were articles in journals like Medical Image Analysis and IEEE Transactions on Medical Imaging, and at conferences like the MICHI conference, the Medical Image Computing and Computer Assisted Intervention conference. And there was a lot going on. And I remember speaking to a radiologist colleague once and telling him about some of the deep learning work we were doing that we had published in a non-clinical journal that focuses on medical imaging and radiology image analysis. And this particular radiologist was completely unfamiliar that we had developed a new technology. It was not a journal that this particular radiologist looked at. And I think the clinical side of radiology just was unaware of what was going on under the surface of the water. There were things going on at a very rapid pace, but they weren't the kind of things that people were submitting to Radiology and AJR and other journals like that. But you asked, have I been surprised? I've been incredibly surprised. Although at the beginning, I did comment in some of my lectures that I saw the technology of deep learning to be a democratizing influence. And by that, I meant that because it was so much easier to do AI with deep learning than it was to do computer-aided detection prior to deep learning, I realized that a lot more people would be able to do it. With the deep learning software, you can download the platform, you can download the architecture, it's all free. People have shown exactly how to do the image processing, so you can almost follow a recipe. Essentially, you need to collect a large data set and label it adequately. And then if you follow the recipe, you can do it. So it became much more attractive to radiologists and radiology image processing researchers who might not have been interested or adept at the arcane art of computer-aided diagnosis, which involved designing features specific to a particular disease. And it became very challenging to do that. For example, for the colonic polyp problem in virtual colonoscopy, we had to come up with mathematics that could measure things like the height of the polyp and the circumference of the neck of the polyp and things about the curvature of the surface of the polyp. You don't have to do that now. You feed the data into the deep learning system and it figures out the patterns. So that very time-consuming, mathematically intense part that we had to handcraft before is completely gone. And I realized that was part of the bottleneck, both for research and for clinical implementation. So in that respect, I did foresee rapid growth, but even so, the rapid growth has been astonishing.
Definitely. I think that the democratization of AI that you mentioned, and when I say AI, I mean deep learning particularly, it's been really cool to see. We can see in courses like Fast AI by Jeremy Howard, where he even says, we want to make deep learning networks uncool again, basically making it accessible to people by bringing high-level software libraries that are very accessible, even if you don't have a super robust coding background. But another piece of that puzzle, I think, for democratization is access to data, and not just data, but data with high quality labels that are medically relevant. You mentioned the COVID-19 explosion of papers. Although I think they were well intentioned, there have been a few systematic reviews that have come out that basically looked at these papers and said there are some very fundamental issues with the clinical details about these studies. For example, some of the chest X-ray data sets, they use non-COVID images exclusively from pediatrics. And so essentially a model is probably learning to tell an adult versus a peds patient. But on that topic, one of your most meaningful contributions and impactful ones in recent years has been several large public medical imaging data sets, including the chest X-ray 14 data set, which has over 112,000 chest X-rays. And this has really formed the basis of countless papers, numerous AI competitions, including the RSNA 2018 Pneumonia Challenge. Can you tell us the story behind this data set? How did it come about? And what was the process to actually release it publicly?
Yeah, that data set really challenged our organizational abilities in my lab and at NIH. At the time, there weren't many large annotated data sets for radiology. And we were preparing a paper for one of the top computer vision conferences called CVPR, Computer Vision and Pattern Recognition. And my team at that time put together this data set, and then we started talking about how to make it publicly available, because we realized the impact of the publication would be much greater if the data set were also available. And the other factor was that in the computer vision community, they already had a number of very large data sets. You mentioned the ImageNet, a large-scale visual recognition challenge, and the ImageNet data set was a very large data set. I think there's something like 14 million natural world images in there. And that data set was instrumental in starting the deep learning revolution. As you mentioned, the AlexNet deep learning architecture was shown to be a high-performing system on that particular data set. So that community was really keen on data sets. My team was very keen on getting that data set released, but we ran into a number of challenges. I guess the first had to do with privacy considerations. NIH wasn't in the habit of releasing large image data sets at that time. There were some efforts to do it. The Cancer Imaging Archive was hosting many data sets, but those data sets tended to be small. We had already posted 2 CT data sets there, the pancreas CT data set and the CT lymph node data set. But those data sets were small. They were on the order of, I think one of them was 80 data sets. The other was something like 150 maybe. And so we had this collection of 112,000 chest X-rays. So then we had to figure out how to make sure that it would be safe to release that patient privacy would be ensured. And there weren't a lot of guidelines about how to do that. We converted the images to the PNG format because we were concerned about information in the DICOM header being used to somehow reconstruct when the patients were scanned and who they might be. So perhaps in excess of caution, we eliminated the DICOM header completely and converted the images to the PNG format. Since there weren't really good guidelines on how to anonymize chest X-rays, I was very concerned that there was something there that we weren't considering. And so we ran optical character recognition on the chest X-rays, and we discovered that in a small percentage of the images, maybe 1 or 2%, there was text burned into the image. And there was no reason for that text to be burned into the image. It was completely unnecessary, but apparently one of the vendors had an option to burn text into the image, and that particular instrument, it was burning information in the image. So we found that with the OCR. And then again, in an excess of caution, I thought, well, what happens if a patient is wearing jewelry that has their name on it? And you can see I'm kind of obsessive compulsive about this stuff. So we did an analysis looking for distinctive jewelry, and we discovered, people are supposed to take their jewelry off before they get their chest X-ray, but it doesn't always happen. And so again, in an excess of caution, I think we used automated techniques to find the jewelry, and then we manually cut the distinctive jewelry out of the image. So once that was done, then the next challenge was where to put it. And the data set by today's standards isn't that big. It's about 40 gigabytes, and there are way larger data sets today that are, at the time, we didn't have anywhere to put it. The Cancer Imaging Archive was reluctant to post it. It just wasn't feasible to put it there. It had to do with cost considerations rather than any other factor. So we sought different approaches. We tried working with a company to post the images, but that didn't work out. And then serendipitously, I learned that our institution had purchased a cloud account. And when I spoke to them, they said the amount of storage was essentially unlimited. I'm like, well, where were you? Where were you over the last 6 to 12 months when we were struggling to find somewhere to put this? So that's when we were all set. We had all the components. We had dealt with the privacy issues as best as we were able. We had dealt with the storage issues. And so finally we were able to post it.
Wow, that's quite the endeavor. And I think that I can probably speak on behalf of many in the radiology AI community that it's been a tremendous contribution. Certainly I've enjoyed working with it, and I know that it's formed the basis of so many works, so many even AI challenges we've talked about. As we move into the last few minutes of our time, I want to ask a question that I ask all of our guests, but I think that has particular special meaning for you since you've been part of AI and computer-aided diagnosis for so long. As we look to the next decade in radiology AI, what are you most excited about, and what do you predict is going to be the direction of the field?
Well, I guess the things that I'm most excited about fall into different categories. One of the things I'm very excited about is that these large labeled data sets are going to continue to become available in increasing numbers. And I think that as time goes by and we get more and more well-annotated large radiology data sets, there will be a paradigm shift where we can use the data sets together to do things that we can't do today. And one example is something that I've been working on called universal lesion detection, where the AI finds all the different abnormalities in the scan, not just one. So, for example, there's this wonderful AI data set that RSNA put together. I don't know if you were involved in it. It's the one on the pulmonary embolus challenge. And there are thousands of CT pulmonary angiograms in that data set. Well, that data set also provides utility for developing all kinds of other AI systems like body composition analyses, rib finding algorithms, lung fissure detection. I mean, you name it, you can come up with all kinds of interesting coronary artery analyses. And then, perhaps there'll be some other data set about thyroid disease or coronary disease or interstitial fibrosis, or whatever. After a while, you're going to have so many of these data sets, and you're going to be able to use them for different tasks. These data sets were initially created for a single task, like pulmonary embolus detection. With the chest X-ray 14 data set, we tried to make that a multi-task data set. So there's 14, it's called chest X-ray 14 because there's 14 labeled abnormalities. That kind of gets at what I'm hopeful for in the future, which is this universal lesion detection, where the AI systems don't just find one thing, but they find everything. And I think that will be helpful for radiologists in the future in terms of increasing efficiency and reducing errors. Another thing that I'm interested in is some of the developing basic AI technologies that kind of haven't hit their stride yet, but may in the future. So for example, how would one create an AI data set for a rare disease? that's hard because the AI systems require lots of images, and by definition for a rare disease, there aren't many people that have it, and so there won't be a lot of images. And yet radiologists can diagnose those scans even with a small number of images. So we've been working on techniques that go by the names of few-shot learning and zero-shot learning. This is a research area that falls under a bigger umbrella called meta-learning, which is learning about learning. And I think that's an area that's pretty much still under the radar in the radiology community, but it's of great interest in the computer vision community, and it's of increasing interest in the medical image processing community. We've published some works on that. Angshum and Paul, a former postdoc fellow in my group, published a few papers last year on this topic. And we've been exploring ways to try to teach AI how to diagnose rare diseases when you don't have large data sets. I also think that the generative adversarial network field is going to have lots of interesting applications. For example, dealing with images obtained using different scanning techniques. These generative adversarial networks can do things like domain adaptation, which means, for example, if you develop an AI system on a contrast-enhanced abdominal CT, you can get that system to also work on a non-contrast abdominal CT. These scans can make synthetic non-contrast CT images. And we've published a number of works where we've been able to teach the computer how to segment organs on non-contrast CT. And I think the same technique can be applied to all the different sequences of MRI scans. So you can imagine scenarios where you'll have segmentation algorithms for T1 weighted, T2 weighted, diffusion images, post-contrast images, you name it. And certainly there are applications, not just in the body, but in the brain. So those are areas that I'm pretty excited about.
All right. Well, you got me excited. I'm looking forward to seeing what the future holds. So with that, Ron, thank you again for joining us here on the Radiology AI podcast. We've really enjoyed having you.
It's been my great pleasure, Paul. Thanks again for the invitation.
And with that, I'll give it back to Dania.
Thank you, Dr. Summers, for a great discussion, and thank you for sharing with us your journey in imaging and AI and your vision for the future of the field. To our listeners, thank you for tuning in to this podcast episode. Don't forget to rate, review, and subscribe to our Radiology AI podcast series on any of iTunes, Google Podcasts, or Spotify. Please stay tuned for our next episode.